So here's kind of the deal, right? So, like I said, the meniscus on the inside part of your knee is flipped forward like this. Now it's kind of impinging, it's caught kind of in the front. And as a result, the reason why you can't straighten your leg out is because this is blocked, okay? And so what happened was it had torn all the way from the back and flipped forward, and that's why we call it a bucket handle meniscus tear. So, when we talk about tear the meniscus, that means a lot of different things, right? Sometimes it means you get a tear here, you can get a tear here, but this is just happens the whole front is flipped forward.
It sounds bad.
Kind of like a taco. And so, when you look at your knee, right, I know I've had an MRI before. So basically, look at this image, right? Bone shows up as black, fluid shows up as white, and cartilage shows up as gray. And so the way that MRI works essentially is your body's kind of getting run through a machine and they're taking slices, and these slices about 3.5 millimeters, okay? So what's going on is, if you ask somebody to count the number of raisins on a loaf of bread, right, they run through a bread slicer, right? When you go through each slice, you see where the raisins are. But in order for you to know where all the raisins are, you have to go through all the pieces of bread. Make sense?
Makes sense.
So kind of similarly, your knee's kind of cut into slices, and we're going from the outside of the knee all the way to the inside of the knee, right? And the inside is where we know the injury was.
Okay.
But on this image sequence, bone shows up as black, fluid shows up as white, and cartilage shows up as gray. And so when you start at the outside of the knee, as we kind of click, this is the front, this is the back, this is the the bone shows up as black. So this is your meniscus actually here. So you see kind of how it's initially starts as a rectangle, but then it becomes two triangles, one in the front, one in the back, right? And it's nice and black, right? And so the other thing is when we see fluid filling cracks or areas where we expect to see structures, that tells us there's an absence of those structures, right? So just like if you took fluid and threw it on the floor, it's going to fill the cracks of the tile, right? So kind of similarly, if we see fluid filling cracks here, we know there's a tear, an absence of something, right? So as we click, the triangle looks nice and black in the front and the back. We get to your ACL. This is your ACL. So that actually looks pretty good, nice and black, right? You see that? Maybe a little bit of scar tissue kind of sitting in the front of your knee. You can kind of see a little bit of that there. But as you keep clicking, right, now this is your PCL, the ligament in the back. And that's pretty good. But now we're getting kind of to the crux of it, which is the inside part of the knee. And so here, right, we're looking for those triangles, right? So this is the front, this is the back, and this is the inside of your knee. But what you see is there's just kind of a whole bunch it's very nondescript. It's not defined. See kind of how over here it's nice and defined, right? But what happened...
That's the outside of the knee first. Now we're getting towards the inside.
Now this is the inside. So if you see here, you see kind of right here, right? If you look closely, there's like two kind of structures. There's one structure here, one structure there. You see that? And all you see is kind of beat up tissue back here. So what's happened is we know that it flipped forward because if you looked at it from the front, right, if you kind of look at it here, right, just to kind of show you again, if you look at the front, it's going to look like two triangles sitting in the front now, right?
This is very informative.
You see that? That's why I know it's a bucket handle tear. Now, ultimately, there are a couple other things you kind of see on your images. One of them is that you also have a little bit of wear of the cartilage. That, it's hard to say if that was related to kind of what just happened as well, but I'll point that out to you. So if you kind of look here, right, this is looking at me now from head-on view, right? So as we're clicking, this is the front of your knee, and we're clicking back. Again, each slice is 3.5 millimeters. We're going click, 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 click. As we click, right, this is your ACL, thigh bone, leg bone, and then here, this is your meniscus, right? You see that? And we know that it tore here because, look again, remember, see there's a big absence there?
Big absence,
But because it flipped forward, it's sitting right there. Part of it's sitting right there. You see, I don't see anything over there. We see it over there because it flipped forward. Does that make sense?
Yep.
And then here, that's the front. That's this kind of game where the back. And maybe there's a little bit of fiber attached, but basically the whole thing's flipped forward. Now remember, cartilage shows up as gray. So the other thing you see here is, if you look closely, you see how cartilage here is nice and gray kind of throughout. Here it's nice and gray. And then right here, if you were to be hypercritically, see there's a little bit of a defect.
I see.
See that's kind of gray, gray, gray. Then all of a sudden there's a little bit of a defect in there. So they're also, that also could have been. There may be a little bit of wear there, or we call it chondral lesion. Kind of what we talked about in your MRI here.
That's what I did into that bottom part.
I didn't read. Let's see. Yeah. So basically, it says partial to full thickness, articular defects in the trochlea. So basically, what it's pointing out is there's a little bit of cartilage wear there, and also if you look at the undersurface of the knee, also unrelated to what happened with your meniscus. There's a little bit of wear kind of underneath the cartilage there. So, so basically, but the question ultimately is, what do you do about all this, right? Because there are a couple of things, right? One, when we see these types of injuries, the answer is we treat them surgically, okay?
Mm-hmm.
Now, theoretically, this is not like life-threatening, right? And the biggest issue is you have a block of the full extension, right? And so, as a result of that, in life, there are only three things that can happen. Things stay the same, they get better, they get worse. We know that with this type of injury, you're still going to have a lock of extension. And the only way to correct that is to surgically go in and basically push the meniscus back, okay? And the other part of that is, what do we do once it's pushed back? Because a lot of it depends on the quality of the tissue, okay? And so, in an ideal world, what we try to do is we try to fix it. So you put stitches in to kind of hold it back, right? But a lot of it depends on kind of what you see at the time of the surgery.
Right.
Okay?
You want to know what you go in.
And the other component of that is if it's going to be able to heal, because the meniscus itself doesn't have a great blood supply, but
that area does, doesn't it?
Well, in the back, the very back
okay.
does, but the inner part doesn't. And so sometimes you get in there and you see that sometimes the tear's been there for longer than we thought, but then maybe you just tweaked it and now you're having pain. It's hard to say.
Right.
But in any case, the goal initially is trying to fix it. But within that means there's a reason, okay? And what it means is you'd be on crutches with a brace, okay, for several weeks. They give you a rehab protocol. And then eventually you gradually start ranging your knee, kind of getting your range of motion back. But really the hardest part's really the first 4 to 6 weeks, where you kind of progressively start putting more weight on it and gradually increasing your amount of knee bending. Usually we restrict your knee bending to about 90 degrees for about the first 4 to 6 weeks, okay? And after that, you kind of slowly increase that, brace comes off, all the while you're strengthening your quad muscles and everything around the knee to kind of give it stability. Usually, from the athletic standpoint, in terms of a typical rehab protocol, and these all vary depending on like how you progress, as well as as well as kind of meeting certain rehabilitation timelines. But typically once you're like 3 to 4 months out, similar to an ACL, it's very similar in that way.
Okay.
So it's a gradual progression to getting on a treadmill and then running, and then eventually getting back to sport-specific activity.
I remember those days.
Yeah, and so basically it's an outpatient surgery. You come and see me about a week afterwards. We check the incisions, you're in the brace. I do like you getting into therapy, sometime before you come in and see me, but the purpose of doing surgery is to do things to reduce the meniscus, decrease your pain, increase your function, okay? Now the other thing about surgery is, by the time you're in there, you actually kind of take a look at where those cartilage areas are and how much wear there is, and have a better idea to assess it. Because when you do a knee scope, you kind of get an idea of how the whole knee looks, right? You actually really look at the ACL
right in
structures.
That curved section.
Yeah.
Okay.
Yeah. So basically the cartilage. So see how thick it's thick over there, but if you kind of click here, you see there's a little bit of a defect. Right?
Yeah.
That's just one of them. But in any case, the other thing that can happen though is when you get in there, the meniscus may not be repairable. Okay, and when that happens, the answer is you have to take it out. Right. Now, long term, when you do that, right, that may mean you'll have a little bit more wear on that part of the knee, right? You already have some signs of some cartilage wear that you see, and that may be the very early sign that there's a little arthritis showing up, but you're a very young guy, so the inclination is to always fix it, okay? But, when you have diabetes, that does sometimes affect healing, okay? And so, I
just got that. 3 months ago.
Yeah, but I'm kind of laying things out.
I got you.
So sometimes that can affect healing, but the reality is like you always try and go in and fix it if you can, and if you can't, then even though there is a little bit of wear, a lot of it depends on kind of if it's fixable. If you get in there and it's just kind of completely shredded, there's not a lot you can do with that. The other component is if it's torn in an area where the healing isn't very good, there's not good blood, I could put stitches in, but it may fail, right? And actually with these types of tears, in general, they have about a 25% chance of re-tearing. And then if it re-tears, we know, okay, it wasn't going to heal, then at that time we go in and take it out. But hopefully it heals, right? Does that make sense?
Yeah.
And so the surgery would be a what we call a left knee arthroscopy, right? So this would go in a small incision. Medial meniscectomy versus repair, partial meniscectomy versus repair. And then we do what's called a chondroplasty, meaning if I see that there's somewhere of the cartilage that may be catching in certain areas that I also think would be contributing to your pain, then we take care of that at the time. Basically risk of surgery is the same. It's bleeding, infection, blood clots, nerve injury, stiffness, pain, possibility of re-tear. complications of anesthesia, right?
Same regular stuff.
Yeah, exactly. We like getting these fixed kind of urgently rather than sitting on them. The concern is the longer it waits.
That's my question.
Yeah, the higher the likelihood it'll be harder for you to get that full extension.
And not even for that reason, but so my wife is handicapped, so it's just me and my 5-year-old son and her. So she had a stroke. So me being down is out of the question.
Do you think you'd be able to tolerate doing like a rehab where you're on crutches for a short period?
Like you mean like right now?
No, like if we did.
Yeah.
Okay.
Well, I'm saying whatever I need to do to get this done I'm willing to do. I just.
Okay. Yeah. So basically, Kayla can come in. We'll try and set this up. Usually kind of with these types of surgeries, we'll get them on the schedule as soon as possible. I was already talking to her outside about kind of how you would do that and when. There may be a slot that we could do it across the street. Okay. Maybe on Thursday, possibly at the surgery center downstairs. But as soon as we can do it, like I'll make myself available to take care of this. Okay. Any questions? Does all that make sense?
Yeah.
I talked for a while. So.
No. It makes sense. I mean, it's kind of what I expected. I just didn't know how serious it was, or because you hear meniscus tears, like I was talking to a friend of mine who had one. He said, "Oh yeah, he was 2 days later he was back walking, felt like brand new."
When there are tears where they're not repairable, that's the case. But when you're trying to fix it, right, the rehab means you're going to be on crutches with a brace for a little bit longer. I may get in there and it may not be fixable, right? If that's the case, that'll be the situation. You may need crutches for a couple of days and you walk without any limitation. But if we're fixing it, then you may have some limitation because obviously we're going to have to try and get this thing to heal if we can.
Yes, this is unbearable.
All right. Any other questions for me?
No, as far as no, because you told me the game plan, the attacks pretty much is a exploration. Once you get in there to see if you can repair it, or if not, you're doing a meniscectomy or meniscectomy to take it out.
You gotta take it out. Yep.
Okay.
Exactly.
Either way, I'll still be able to bend my knee afterwards. If you do the other one, I might have to. I might develop some arthritis or something.
Yeah, you may already because you already have a little bit of that right there, right?
Okay.
So, but the hope is that we fix it and then it heals. But if I get in there and it doesn't look like that's possible, we just resect it and then go from there. But the reason to fix it is because if it's a bucket, we can fix it. Yeah. Right? Make sense?
I'm a realist. Yeah, there is no other option. I mean, for me, because I cannot bend my knee.
Yep.
So
yep. We'll get this on the book very soon. Okay.
Appreciate it.
All right, and then
Dr. Carter, yo.
Yeah. Okay. All right.
Thank you.
All right, no worries. Thank you.
All right, so y'all heard it. Your boy got to get surgery possibly this week. More serious than I thought. So make your next move your best move, make it a boss move. I'm gonna make sure my next move is make sure this knee moves. You dig? All right.